Hello everyone, this is my talk on puberty, the norm and abnormal. I will start off with some definitions of normal, abnormal and commonly used terms. I will go back to some physiology. I will discuss classifications and etiology of abnormalities. I will give tips on history taking and examination of patients. I will discuss appropriate investigations and thereafter appropriate management. Puberty is defined as the physical transition of adolescence or transition from sexual immaturity to sexual maturity. Adolescence is the physical but also the cognitive and psychosocial maturation to an adult. Physical changes include development of secondary sexual characteristics, growth in length, achievement of fertility, and the maturation of body systems such as bone, brain, and the cardiovascular system. Defining the normal age of onset of puberty is very difficult, as it is very broad among children around the world. Abnormal timing outside of a range is considered either precocious, which is puberty before 2 to 2.5 standard deviations below the mean age of onset for that population, or delayed, absence of the signs of puberty 2 to 2.5 standard deviations above the mean age of onset of puberty for that population. Other definitions include gonadarch, which is activation of the gonads by FSH-LH, adrenarche, the increase of androgen production, telarche, which is breast development, menarche, the first menstrual bleed, and pubarche, the appearance of pubic or axillary hair, acne, and apocrine body odor. Going back to some physiology. During early fetal life, there are initially high levels of FSH and LH. During pregnancy, later on, the negative feedback from maternal estrogen and progesterone decreases the gonadotropins. At birth, there is a release from this negative feedback with an increase of LH and FSH for the first 3 months of life. Thereafter, there is an intrinsic inhibition of GnRH. There is little known about the exact mechanism on the timing of the release of inhibition of GnRH. Multiple factors play a role, like genetics, overall health, body fat percentage, and leptin, as well as other interesting factors like height above sea level and the area the child lives in. The onset of puberty is recognized by an increase in pulsatile GnRH. This increases the frequency and the amplitude of FSH and LH that are secreted, and this stimulates sex steroidogenesis and gametogenesis. We need to know the normal sequence of puberty in order to recognize abnormalities. First, breast budding or telarche appears. Then, the growth spurt. Thereafter, the pubarche and adrenarche, where adrenal androgen secretion starts. And lastly, menarche, the first menstrual bleed. This image reminds me of a time when I went through puberty. Yes, I'm giving away my age. I was lucky enough to have a few of these items depicted here to help me through the difficult time that is puberty. When a patient presents with either precocious or delayed puberty, a thorough history and clinical exam is indicated. It's important to note the current age of the patient, the age of onset of symptoms as well as the sequence of symptoms, the rate of progression of puberty. You need to ask about central nervous system symptoms, headaches, or any visual symptoms that are abnormal. You need to ask about rapid weight gain, which can be a cause of precocious puberty. You need to inquire about medical history such as head trauma, chemotherapy, or radiotherapy. Ask about the family history and get an idea of the parent's age of onset of puberty. You also need to ask very specifically about treatment history or any other treatments or gels or creams the patient could be using that could contain exogenous sex steroids. When examining the patient, you need to examine the height and weight, as well as the height velocity in follow-up visits. In your general exam, you need to note if there is any acne as well as cafe au lait spots on the skin. You can do a visual field assessment if there were any symptoms from the history. A thyroid exam is important, as well as Tanner staging of breast and pubic hair. You need to examine the abdomen for any pelvic masses. And then lastly, look at the external genitalia for the signs of estrogen effect or virilization in females. This is a reminder of the Tanner staging from stage 1 through to 5, looking at breast development and pubic hair distribution.
I will now focus on precocious puberty, which is in practice defined as the onset of secondary sexual characteristics in females below the age of 8 years and in males below the age of 9 years. Precocious puberty could either be classified as central precocious puberty or peripheral precocious puberty. Central precocious puberty, in most cases, are idiopathic. They could also be due to central nervous system lesions, such as hematomas, adenomas, congenital abnormalities like hydrocephalus, or acquired reasons like intracranial infections, radiotherapy, or chemotherapy. Precocious puberty could also be caused by GnRH-producing tumors that are extracranially located. However, these are very rare. And lastly, central causes could be due to long-standing peripheral precocious puberty. Peripheral precocious puberty could either be from an ovarian origin due to estrogen or androgen-secreting tumors in either granulosa cell tumors or Sertoli leydig tumors, respectively. Peripheral precocious puberty could also be from an adrenal origin, either congenital adrenal hyperplasia, Cushing syndrome, or tumors of the adrenals that could be secreting androgens. Peripheral precocious puberty could also be caused by exogenous sex steroid use, severe long-standing hypothyroidism, or McCune-Albright syndrome, which is characterized by fibrodysplasia, cafe au lait spots, and precocious puberty. Central precocious puberty usually shows isosexual signs that just occur early, and they occur in a normal sequence. Peripheral precocious puberty could either be showing isosexual signs or contralateral signs, in the case of an androgen-secreting tumor in females, for example. These signs usually occur in an abnormal sequence. A third and newer classification of precocious puberty has been described: isolated variants. Premature adrenarche is the first option. This is characterized by the appearance of pubic and axillary hair prior to the age of 8 or 9 in girls and boys, respectively. This is also with a mild elevation in serum DHEAS for their age. This is considered a variant of normal development, but may be a risk factor for later development of polycystic ovarian syndrome in girls. Next up is premature telarche. Most cases are idiopathic and present under 2 years or even from birth. Many cases will remit spontaneously, and most others do not progress. However, follow-up is warranted because premature telarche can represent the initial presentation of true central precocious puberty. Non-progressive or intermittently progressive precocious puberty is a subgroup of patients that presents with what clinically appears to be central precocious puberty. that will either have stabilization or very slow progression in their pubertal signs. The bone age is typically not advanced compared to children with true central precocious puberty, and the LH concentrations are within the pre or early pubertal range, indicating that the HPO axis is not fully activated yet. Monitoring for evidence of pubertal progression is important to distinguish these children from those with true central precocious puberty. And if this is confirmed, treatment with a GnRH agonist is not needed because the adult height is not affected. Lastly, benign prepubertal vaginal bleeding. This is characterized by the presence of self-limited isolated vaginal bleeding in the absence of other secondary sexual characteristics. The underlying etiology is usually unknown, but potential mechanisms include increased endometrial sensitivity to circulating estrogens or transient stimulation of the HPO axis. In these cases, genital or vaginal trauma, infection, and sexual abuse should always be excluded. Investigations for precocious puberty. In all types of precocious puberty, a bone age should be determined by taking an X-ray of the non-dominant wrist. Abdominal ultrasound and/or pelvic ultrasound could be done if an adrenal or pelvic mass or tumor is suspected. CT brain and/or MRI could be done if there are any central nervous system signs or symptoms. An MRI should be done in all males that present with precocious puberty and in all females less than 6 years of age. Central precocious puberty will show high LH levels. Normal prepubertal LH levels are less than 0.1. If these levels are above 0.3, this is immediately diagnostic of precocious puberty overall. If the levels are above 5, this is indicative of central precocious puberty. However, if the levels are between 0.3 to 5, then a GnRH stimulation test is indicated, which will reveal very high levels of LH in the case of central precocious puberty. An LH-FSH ratio could also be done, which will be more than 1 in the case of central precocious puberty. Prolactin and thyroid function levels could also be done if indicated from the history and/or exam. In peripheral precocious puberty, the LH as well as the FSH will be normal. And if a GnRH stimulation test is done, this will stay less than 0.3. Estrogen and testosterone levels could be elevated in the case of a secreting tumor, respectively. DHEA or DHEAS could be done if an adrenal tumor is suspected. 17-hydroxyprogesterone is indicated if congenital adrenal hyperplasia is suspected. Once again, prolactin and thyroid function levels could be done if this is suspected from the history and/or exam. And lastly, an HCG level should be done if an ovarian tumor or mass is suspected. This algorithm shows precocious breast and pubic hair development investigations. First off, you will do the bone age as well as the gonadotropin levels. Thereafter, as said before, depending on the results of the LH levels, a GnRH stimulation test could be done. If this reveals central or gonadotropin dependent precocious puberty, a head MRI could be done, or thyroid levels depending on the history and examination. If this is peripheral or gonadotropin independent precocious puberty, the hormone levels could all be done. And for both, an abdominal or pelvic ultrasound could also be done. Treatment aims for precocious puberty include maximizing adult height, stopping or regressing secondary sexual characteristics if possible, preventing an early menarche if possible, and avoiding psychological and behavioral issues, as these are commonly present with patients that present with precocious or even delayed puberty. Management of precocious puberty. If the cause is central, like a central nervous system tumor, resection is indicated if possible, except in the case of the hypothalamic hamartomas. First-line medical treatment is GnRH agonists. There is good evidence to show a significant increase in height with the use of these agents. It is important that therapy and patients are monitored at regular intervals with bone age as well as growth velocity. GnRH agonists are stopped at the time for normal puberty for that population, or when adult height is achieved. Growth hormone could be added to GnRH agonists if the bone age response is not adequate with the above. The evidence is even better for a response if the age is less than 10 years when started. In the case of peripheral precocious puberty, the cause should be identified and managed promptly. Ovarian or adrenal tumors should be resected if possible. In the case of congenital adrenal hyperplasia, glucocorticoids are the mainstay of therapy. Exogenous treatment should be identified and immediately stopped. Hypothyroidism should be treated, and in the case of McCune-Albright syndrome, treatment involves the inhibition of steroidogenesis with aromatase inhibitors or selective estrogen receptor modifiers. With both types of precocious puberty, it is very important to remember about contraception. Patients should be counseled and offered contraception as soon as possible, as they are more prone to behavioral issues, teenage pregnancy, and promiscuity. When I went through puberty, these were some of my favorite movies. I know most teenagers growing up in the 2000s had either a poster in their bedroom on their wall of Leonardo DiCaprio or Brad Pitt, or both, just like I did.
Next up, I will be focusing on delayed puberty. In clinical practice, this is defined as the absence of breast development by 13 years in females, or the absence of testicular enlargement by the age of 14 years in males. Stalled puberty is puberty that is not completed within 4 years of onset.
Delayed puberty could be classified either as primary or hypergonadotropic, secondary hypogonadotropic, or eugonadotropic. In the case of hypergonadotropism, the cause is ovarian failure, either with an abnormal karyotype or a normal karyotype XX or XY. In the case of hypogonadotropism, the cases could be reversible or irreversible, with the subsequent causes listed as seen in this table here. When the gonadotropins are normal, this could show an outlet obstruction or an absence of the uterus, like Müllerian agenesis, or an obstruction like the vaginal septum or imperforate hymen. It could also be due to androgen insensitivity syndrome or just an inappropriate positive feedback. Appropriate investigations for delayed puberty. Once again, for both types, the bone age is indicated, as well as a CT brain or MRI if there are any central nervous system signs or symptoms. For hypergonadotropic delayed puberty, LH and FSH levels will be high, estrogen levels will be low, and a karyotyping should be done. Prolactin and thyroid levels once again could be done to rule out any endocrine causes, and DHEAS could also be done. In the case of hypogonadotropic delayed puberty, LH and FSH could be normal or low. Estrogen and testosterone levels will also be low. And once again, prolactin or thyroid levels could be done if indicated. This is a simplified algorithm for investigations for delayed puberty. First off, gonadotropin levels and estradiol levels should be done, as well as X-rays to determine bone age. This will then either point to hypergonadotropic hypogonadism, as explained before, where a karyotype is always indicated. If it shows to a hypogonadotropic hypogonadism, a head MRI or CT scan could be done if there are symptoms and signs of central nervous system involvement or pathology. A full blood count, ESR, and liver function tests could be done if chronic illness is suspected. And lastly, endocrine levels for prolactin, thyroid levels, and DHEAS could be done. Management of delayed puberty. Once again, the aims are correcting the specific cause, fostering age-appropriate secondary sexual characteristics, and inducing the growth spurt to maximize adult height. In the case of isolated GnRH deficiency, hormone therapy is indicated, which is usually started at 12 years of age and stopped at normal menopause age, at about 50. Oral or transdermal estrogen is given, usually at lower doses than adults. This is increased 3 to 6 monthly depending on breast development. No progesterone is indicated until substantial breast development is achieved, or breast plateau. This is about 2 years or more after the treatment with estrogen has been started, or when a breakthrough bleeding has occurred. Growth hormone treatment is only limited for growth hormone deficiency. It's also important to treat the cause. Thyroid treatment if hypothyroid, dopamine agonists if there are high prolactin levels, the management of chronic diseases, treating of malnutrition, and surgery if there is a tumor mass or an obstructive septum or imperforate hymen, for example. In conclusion, it is important to remember the normal sequence of puberty in order to be able to identify abnormalities of puberty. Do not delay the diagnosis. A thorough history and examination is always indicated, as well as appropriate investigations. We have to avoid the psychological and physical sequelae of these abnormalities of puberty. Puberty is hard enough as it is.